Welcome everyone to today's HealthIT Symposium. During the presentation, all participants will be in the listen-only mode. Should you wish to ask a question during the presentation, please use the Q&A feature. This symposium is a collaboration between the National Center for Primary Care's Faculty Development Program and Hybrid Solutions. I'm Shanae Lee, Associate Project Director of the NCPC Faculty Development Program at Morehouse School of Medicine. The mission of the Faculty Development Program is to provide resources and education to faculty, clinicians, researchers, leaders, and scholars that will improve knowledge and skills. I'm glad you all could join us today to talk about the growing healthcare industry. Your host today is Phoebe Nelms, Program Manager with the HealthIT Division, Hybrid Solutions. Phoebe?
Thank you so much, Shanae. We're all very excited to partner with faculty development to bring this event to life. So get ready for a fast-paced information upload. We intend this to be an engaging discussion with industry experts who will share actionable insights on where we are on that journey to interoperability. We'll also talk about the requirements of the 21st Century Cures Act and how it will impact the delivery of care in your healthcare organization. We also have a segment on what's happening in Georgia, as well as an interactive panel discussion focused on using digital health technologies to improve the quality of care, care coordination, and enhance the communication between physicians and patients. Mahatma Gandhi said, "It is health that is real wealth, and not pieces of gold and silver." And so the mission of the National Center for Primary Care is to strengthen the primary care system and work that it does to keep us all healthy through educational events like this one. And now I have the pleasure of introducing Dr. Dominic Mack. Among his many titles, Dr. Mack is the director for the National Center for Primary Care here at Morehouse School of Medicine. The Faculty Development Program and the HealthIT Division fall under his leadership. The HealthIT Division's executive director is Carmen Hughes, and the HealthIT Division includes Hybrid Solutions, Hybrid HIE, Health Information Exchange, and our new project, Aim Ahead. We are looking forward to hearing from today's diverse group of healthcare experts. And now, Dr. Mack, you have our attention.
Thank you, Phoebe. And I want to thank, thanks, Shanae. I want to thank all the panelists we have today, and we really thank our audience for chiming in. Just a few words I'd like to add today is about, one is about the Faculty Development Program. A little history. Faculty Development Program was started in 1992 within the Family Medicine Department of Morehouse School of Medicine. We were experiencing challenges retaining minority faculty at that time. And the Association of American Medical Colleges reported that there were only 52 African-American full-time academic physician faculty across the nation. And that started the development of this program. And studies since have identified, I know in 2013, there were only 7.5% of faculty members who identified themselves as underrepresented faculty across this nation. So the Faculty Development Program is so important to develop minority faculty who serve at minority institutions, but also majority institutions. So that's the purpose of the program. So Phoebe kind of gave you a little background about the National Center for Primary Care, but that Faculty Development Program followed Dr. Russ to the National Center, from the Family Medicine Department to the National Center for Primary Care. And of course, we have other programs. The HIT program, Health Policy is another one of our cores, along with our research core. So we do a lot of big data, health equity research here. We do a lot of implementation science, especially on the HIT division, where we implement, since Meaningful Use, we've been implementing programs around technology in the United States, and now we actually have some programs in Zambia. But anyway, just want to say hello to everyone and thank you and welcome you today. And I want to turn it back over to Phoebe.
Thank you so much, Dr. Mack, for highlighting the important work being done here in the National Center for Primary Care. We eagerly anticipate the information and the opportunities for collaboration that this symposium will produce. Next, we'll give our attention to Dr. Gary Ozonic, a senior consultant for Health Tech Solutions and director of the graduate program in Health Informatics at Northern Kentucky University. His extensive experience with the Office of the National Coordinator, ONC, and the Health Information Management Systems Society, HIMSS, also informs his topic today. And although interoperability seems to be an elusive goal, help is on the way through ONC leadership and direction. Dr. Ozonic, please tell us more.
Thank you so much, Phoebe, and it's a real honor to join you this afternoon. An agenda today, and as suggested, Phoebe suggested, it's going to be relatively a quick fire, and we're going to be going through a lot of information, and look forward to any questions that you have and would like to include into the chat, which we'll take in at the last part of this presentation. So what I want to talk about today is data integration and clinical practice, and some market-based and policy solutions, and then finally a future vision, and ideally engage some of the attendees in thinking about what that future should be. Next slide, please. So this is really about interoperability. This is about levels of data integration, right? I mean, interoperability is about getting ideally health data to the right place at the right time. But what we're really concerned about is being able to integrate data into, various use cases, whether it's the point of care or care coordination or quality reporting for MIPS or other value-based programs. Also, ultimately for population health, and data integration is more than just the sort of structured clinical data. We often think about, clinical measures that are actually much easier to deal with than the more important, health equity measures of social determinants and the like, which tend to be unstructured data or semi-structured data. So there's a lot of complexity in data integration, but just to sort of give you a map for looking at data integration and interoperability, the question is workflow. If it's not really being supportive of workflow in the specific use cases where it's important, clearly there's limited utility, and perhaps providers and others may not take full value of the data. So where we really started before the Meaningful Use program was a lot of siloed data within one health system, and ideally now we're moving toward higher levels of integration where there's much more integration into workflow. Then usability, and we're going to talk a lot about usability, because if you get data to the point of care where it's not useful, it's really not true interoperability or data integration. And then finally, the technology. And we start, focusing initially a lot on technology, but increasingly we're going to be technology agnostic, and we just want to have a semantic understanding of the data across all settings. That is, the ability to map data across a variety of settings. We're just finishing a study right now, and actually next week, Wednesday, we're doing a webinar for HIMSS on a project that ends on March 31st. That's funded by ONC and by ASPE. And we've been looking and talking to organizations and case studies about, what level of integration they're at, and how they use data. And the major takeaway that we came up with is that we automatically assume you want to be in the lower right. You want to be as far to the right as you can in terms of this map. But in reality, in some cases, you don't need the highest levels of data integration. Viewing data is sufficient, as opposed to, you know, the need for parsing data. And we'll touch upon that again as we go through. This just sort of gives you a roadmap on where we are in terms of interoperability. If you're able to send data, that is, send it through an HIE or Care Everywhere if you're an Epic customer, or Commonwealth or the eHealth Exchange, any one of the various exchanges. And you can see hospitals are way out in front of office-based physicians and you know, home health agencies and SNFs. You can see how we look across the spectrum here. And then if you're able to receive data, are you able to find data and look for data that you need? And then ultimately, can you integrate data into your workflow? Are you actually using the data from outside sources when you're seeing a patient? And as you see, there's, you know, a significant drop off. I mean, it's easy to send the data. It's easy to receive the standards-based data, but then can you really integrate it? And can you use it to basically find the data you need? And you can see various care settings, you know, not surprisingly, skilled nursing facilities and are lagging office-based providers or hospitals. So we still have a ways to go. And that's, you know, the baseline we're sort of looking at right now. And we want to talk about how we're going to make things better. Help is on the way. Next slide, please. So key uses of data interoperability and data integration are point of care, where you see a patient that is, you know, during the actual encounter. Example of this is looking at the health information exchange, such as GHIN, and seeing the patient record, or if you're an Epic customer, looking at Epic Care Everywhere and being able to see that a patient has been seen at another location, or has had recent labs or other tests. You can cut down on relative redundant tests and the like, save money, and also get the most recent information on the patient, particularly when medical histories may be complex to capture. Care coordination, obviously, between transitions in care, whether hospital release from hospitals, linked to, you know, 30-day readmission concerns and the like, or between post-acute care and hospitals. But also a key element of care coordination is referrals to specialists and getting information back when you're referring a patient for care coordination. So point of care and care coordination really do not require the level of interoperability or the level of data integration. You can basically view, you know, past data in the patient, and it's sort of good enough. And that's where we are. Even if you're looking at a single vendor system like Care Everywhere or Commonwealth, the providers are really looking at the data. It's not being integrated into a single patient record. Quality measurement and reporting is a third area that's obviously linked to MIPS. We've just been doing a lot of organizational interviews as part of the study I mentioned earlier. And we're hearing from providers that their quality scores actually go up when they're able to get data from other sources and integrate it into the into the record for the patient they're reporting on. You know, whether it's tests being done elsewhere or follow-ups or whatever the particular HEDIS measure might be. Population health is really the future. I know you're going to be talking about AI today and predictive analytics, tracking, public health linkage. Boy, we've learned a lot about COVID in the last 2 years and the gaps in terms of interoperability relative to public health and population health and the like. So that likewise requires, you know, very carefully mapped data, and it is quality measurement reporting and pop health really are use cases that really require a lot of data curation, a lot more expense than the first two use cases. So what are the challenges to data integration? we have technical interoperability. You have, if you look at non-certified EHRs, for example, if you look at long-term post-acute care, probably depending on what state you're in, 60 to 80% of the market is point-click care, and they don't really, they're not a certified EHR because they were not included under the original meaningful use requirements. You also have a lot of issues about the technologies being used and the standards being used. And I'm going to talk about this. The specificity of standards is really important. I mean, I think the big lesson we learned in the last, few years is really, even though we have good standards, you can exchange data and it may not be usable at the receiving location. The standards have to be very, very specific. And we're going to talk about solutions, particularly in the form of a standard called FHIR and Smart on FHIR. That's a solution for that. Semantic interoperability refers to data mapping. That means if you're mapping an A1C from one provider into another vendor system, that it's recognized and placed in a usable format so you can understand it. Semantic interoperability is different than technical interoperability, and in many ways much more expensive to achieve and much more difficult. Then also challenges is workflow integration. How easy is it to use and how complete is the data? And then the data characteristics themselves, structured, unstructured, and semi-structured data. As we're learning, so much of the important data is really unstructured. So much about healthcare and issues of really moving the needles in terms of care has to do, as you well know, with social determinants and with other data elements that are not very easy to map between systems. It's much easier to map a lab value between a system than it is to map text or even a checkbox survey. So the data characteristics are another challenge to data integration and interoperability. So what's enhancing data integration today? Next slide, please. So the marketplace really is at an inflection point. If you've been involved in healthcare during the stages of meaningful use and promoting interoperability as it was shifted to in 2016, it used to be the standing joke, and I served on various committees at HIMSS and in various capacities, but the standing joke always was that meaningful use was actually meaningful abuse for the providers. That so much of the initial introduction of the technologies required a burden on providers. And certainly what ONC is doing today, and I had the opportunity to work on the EHR reporting program, which is currently in a public comment phase, which is a identification of new standards for EHR developers to be certified under ONC. But one thing we've really come to understand and appreciate is relieving burden on providers. Technology should help providers. It should not be a burden on providers. And during our last few years, and particularly the initial years, a lot of the technological adoption was just not supported or justified given the utility of the products that were being used and adopted. And in some cases, you still have reports of providers being held captive to EHRs that they really can't get out from under on a relative to financial burden. So the idea is really to really look at the certification technology, and a key element of the certification technologies that continues to evolve is to reduce provider burden. So technology is shifting, but standards and policies are being refined. the current policies and current standards are somewhat cumbersome for interoperability, and that's been recognized by the ONC and certainly is recognized by the marketplace. There's a technology that we'll talk about called FireFast Healthcare Interoperability Resources, which is going to change the nature of exchange. ONC is certainly making a substantial focus on FHIR and its ability to solve some of the interoperability problems that we're facing. APIs stands for Application Programming Interfaces, and that's really the backbone of the internet. So for example, if you go to an Amazon site to look at a product, it's my understanding, the quote I've always heard is that on average it'll connect to 54 different different information sources through application programming interfaces. So as you'll see, we're going to be moving away from so-called document exchange of large portions, large documents in the form of continuity of care templates, and moving to what is now the USCDI data elements, and we'll talk about that in just a bit. So we're going to move more to point-to-point transactions and away from these bulk standards. Also, you have national networks. You have the eHealth Exchange and you have TEFCA, which are certainly designed to provide fewer hops in terms of exchanging data and potentially allow for providers to, connect through an HIE-like organization in regions where there's no HIE. You have vendor networks, and I often joke that I suffer from Stockholm syndrome, and that I'm actually a really big fan of Epic's Care Everywhere network. I think it does a really good job for its customers. But you have Commonwealth also, which is sort of the Cerner and the other vendors, and they've certainly become affiliated with the national networks. So ultimately, we're going to have a variety of competing and complementary ways to exchange information. And I want to talk about some specific ones that are going to make your life easier. So the drivers for interoperability is the movement to value-based reimbursement and risk-sharing models. I mentioned that, in some of the recent interviews we've been doing with providers, and the providers were specifically identified based upon their involvement in value-based accountable care organizations. They've identified that getting a full picture of the patient from every place possible really has improved their reimbursement and the upside in their risk-sharing models. Population health and analytics, you'll talk about this later this afternoon, but clearly predictive analytics, big data, data warehouses, data lakes, and the like. Payer engagement, increasingly the payers and providers are exchanging some data within a health information exchange. There is still a significant trust component that needs to be encouraged between providers and payer organizations. In the research work, the survey work we've done, we still hear that providers are worried about sharing all their clinical data with payers because the payers may use it to complicate pre-cert and stuff like that. But that's another area where there is movement, simply because if you're in a risk-sharing model, you're going to have to share data. And then open standard application programming interfaces like FHIR and consumer-directed exchange. One element of the Cures Act really is to require the ability for third parties to use APIs, to basically use FHIR or proprietary APIs to aggregate consumer data and allow the consumer to direct exchange between various providers. So, theoretically, you could have a large company like well, I doubt Google would want to be in return to the business, but you could have a large company that's a high-tech company essentially aggregating data for consumers and then making it available to providers. So, you know, interoperability, mentioned Care Everywhere. We have EHX. We have that's the eHealth Exchange alert services. Use case everybody appreciates. We have business models that are basically expanding beyond simple commodity exchange. And as I mentioned, the Cures Act is accelerating the potential of third-party aggregators of patient data using APIs once the patient gives permission. TEFCA, I won't spend a lot of time on this, but this essentially provides a national backbone and potentially regional qualified health information networks to be connectivity brokers between HIEs. This is a part of the Cures Act and has been rolled out in the last 6 months. It seems to me quite successfully by the TEFCA team and also with the ONC support. So that is one way to exchange data. Next slide. So you're going to see a national flattening of the national infrastructure. Increasingly, you're going to have rules of the road that's going to allow better exchange between exchanges themselves, much like you're seeing within a single vendor network. And ultimately, you want to reduce hops between locations and flatten the infrastructure for all stakeholders. Frankly, users should not know what infrastructure they're using. It should be as agnostic to you as whether you're using Verizon or AT&T. Yeah, so COVID and public health. Obviously, this is a key topic, and the exchange of lab and LOINC standards and SNOMED coding were a huge problem, but I think this has got everybody's attention now. Happy to discuss this if you have Q&As about it. Next slide, please. So quick discussion. So the Cures Act summary, we're really talking about consumer access to electronic health information, you know, EHI. And so the plan here is that consumers will have access to a broad set of data at no extra charge on an unrestricted basis through open source APIs such as FHIR. So you can go to a third-party aggregator, give them permission to access your records at the various providers where you have a record, and they can aggregate that, and you can direct it yourself as a consumer between your caregivers. Provider directory, that's really important, really relative to care coordination and value-based care. We need to be able to attribute patients to providers and providers to patients, right? How can you coordinate care if you don't know what providers are seeing patients, and how do you know where to send your notes if you can't find providers attributed to a patient? Patient matching continues to be a challenge, but there's new algorithms out there, which is a whole other technical story, but we're trying to improve patient matching, and there's some new approaches to that. I think we'll just focus right here on 3 and 4, which is application programming interfaces and the US core data set. I should mention we are in USCDI version 2, and not 1, but initially Cures require the use of the core data set, and we'll look at a slide on that in just a second. So just very quickly, health information exchange and interoperability was based upon something called a consolidated clinical document, or a CCD. And it's very large program. If you're a provider and you've ever looked at a patient record and seen 50 or 60 or 70 pages that you really can't search very well, you're looking at a CCD. They're difficult to use, difficult to integrate, and all data are basically treated somewhat similar. So you don't recognize, for example, you know, the key data elements such as, you know, PAMI and other high utility data. So the Cures Act says we're going to support APIs, and FHIR is the leading standard for that, to replace CCDs. Next slide, please. So this is what a CCD looks like, just so you know. It has a total of 58 various templates. And you can see they're important: allergies, medications, discharge meds, dictation, and the like. The problem is every time you send a CCD, everything goes. And normally it would be received as a PDF, and not very easy to search, not very easy to look through, and really impossible to parse effectively into the receiving electronic health record. So while everything in here is important, you're really looking at, you might call a Concord solution, right? You're looking at something that can go faster than the speed of sound, when really what you need is a commuter jet. You don't really need all of this information. So this is what UCDI version 1 looks like. You can see that it's very simple, discrete, and it's been replaced by 2. And there are some new elements in 2 that include provenance, clinical notes, patient identifying information, and pediatric vital signs. Those are the new elements on the bottom that are now part of USCDI v2. So once again, all of these, as a provider, you can see how they're all really important to you, right? Now, here's what's really cool, is we can use FHIR, which is an API, to come in and just request labs, or we can do a query and just request clinical notes, or we can do a query and just request medications. But even right now, just if you do a bulk transfer of all the data elements, it's not as overwhelming as the CCD used to be. So this means 2 things. One is it's going to be easier to deal with on the receiving side and parse it into the record or make it available to the provider. And also, it's going to be easier to basically organize what you need and how it's used. So FHIR basically, APIs, application programming interfaces, is really a policy response to that bulk data of CCDAs and the HL7 standard, which many are frustrated with relative to all the bulk data, moving to more of a document-based exchange and a focus on high-value information. You also have third parties driving consumer-directed exchange. So you can see, if you're moving to modularity of data and moving to a means of exchange that it can be far more discretely focused in terms of looking at the data elements, it's going to provide a lot of relief relative to the frustration that we face with interoperability. So questions for you. If you don't have questions for me, I have questions for you. Next slide, please. What will data integration look like? Will providers want a single record, unified? Or will they still want to know, this is what I've done, this is what we've done in our health system or at my practice, and I want to look at anything coming from another location as separate? What's the data provenance? Where's it from, and what about the liability of integrating data from outside sources? It's not really clear that the maximum level of integration is most important. Other questions I have for you is, will consumer-directed exchange by third parties be successful? Will consumers basically work with third parties to allow them to aggregate their health records, and then in effect be the exchange entity for that? Will vendors increase cooperation, or are you going to still continue to have a degree of competition between vendors? And then finally, what are we going to do about sources for data contribution that we need? What about behavioral health? I'm working on a project right now for the Commonwealth of Kentucky, with substance use disorder and just the frustrations of data interoperability is so huge. And, understanding who's being treated where, for example. What about community organizations? How do we get data from them and to them? And most importantly, how do we, enhance care for the patients? So with that, I'll take questions. You can answer my questions or you can ask me questions.
Wow, that was an incredible view of the past, the present, and a glimpse into the future. Thank you so very much for highlighting those policies that are being implemented to support a learning health system through the collection and secure exchange of electronic patient data. A few questions that we'd like you to address for our audience. In your presentation, you highlighted the numerous barriers to interoperability and data use across care settings. And you suggested that there will be solutions to those barriers in the very near term. What is the single most important solution and what barrier will it address?
In my opinion, it's the marrying of the USCDI, the Universal Data Set, in its modular context with the power of application programming interfaces to basically go in and capture discrete data elements. No longer will you have to deal with the frustration of trying to do the data mapping when you bring in an HL7 standards compliant a message and try to map it between even the same vendor systems or different vendor systems. Also, it will be able to concentrate on the data elements that's most important to particular providers at particular times. What's really opened my eyes is I was somehow always thinking that we just wanted max integration, right? That we just wanted to parse everything into one single record. But what we've learned in a lot of the qualitative research we've done over the past 2 years or so, 3 years, is really that a lot of the providers just want to know where to look for in the EHR the information and where it came from, right? Where do I find it? And what's its provenance? Who did the test? Can I trust it? Right? And that is a lot lower threshold to reach than actually parsing and having a single unified record. So I think there's going to be, and I think APIs and FHIR and USCDI sort of support that, small ball value. What's a money ball, right? You exchange the high value discrete pieces of information as opposed to everything. So that's what I think.
That's awesome. Clinicians are so extraordinarily busy that anything that makes their lives more simple and gives them the information exactly at the point of care is priceless. Another question, what does the vision you provided mean for individual providers and for patients, and how will care be affected?
Yeah, that's hope is, I know hope is not a strategy, right? But that's a really with the most important question, right? Hopefully, we are removing some of the burden from providers. We're able to get a more complete picture of the patient so that with limited or a little effort, they're able to get the information they need at the point of care and to coordinate care, which perhaps is an overlooked area. And then I think for the patient, it's always frustrating because, if you look at the original data on patients signing up with patient portals, it was always such a struggle to get to 5%, right? And you still do not have the usage of patient portals that you would think. But there's a lot of problems with each portal is tethered to provider. I know my chart's trying to incorporate data and the like, but the idea is you free the data with third-party aggregators, and you have younger demographics who are used to using technology and data differently. That perhaps we're going to begin to look at data exchange and data use differently on the patient side too. Certainly the ability for the patient to be empowered, I believe, is being enabled. Whether the patient takes advantage of that enabling, right, is always the challenge.
Yes, most assuredly. But having it available and easy to use is a first step, at least. We want to thank you again so very much for the wealth of information that you shared with us, and you kind of gave us that glimpse into the future, as mentioned. We know that healthcare data is highly prized by not only the well-meaning healthcare industry and the clinicians and the policymakers, but it's also very highly prized by nefarious characters. And we want to have that balance between involving patients in the management of their healthcare. That's a really high priority, as you mentioned, but then we also need to protect that data as well. Our next presenter, Mr. James Hunter, is the Chief Information Security Officer here at Morehouse School of Medicine. And he'll discuss a little bit more about the 21st Century Cures Act, the requirements, how they will impact healthcare organizations, because they do pretty much impact all healthcare organizations. And we'll see how maybe we can achieve that balance between making the involving patients in aggregating and sharing their information while also keeping it secure. Mr. Hunter, please share with us.
Yes, thank you for having me. Glad to be with you today. Today we're going to look at two of the areas that we want to focus on, which is the how does the Cures Act final rule means for patient access, and then we'll also look at information blocking. So we want to look at those two, and when we look at the final rule and what it means for patients, they want to achieve to give the patient greater access to their records, and not just through paper, not just through notes. They want to achieve by doing that with smartphones and mobile devices that we have today and modern software apps. And also while doing this, they want to achieve this by making sure that patient privacy and security is the utmost importance. So they do use security technologies that have to be authorized within the applications and the APIs that was discussed earlier, to make sure that they are using protocols that the government and has given authorization to use. And one of those is such as OAuth 2, that is a very highly secure protocol, which is used in today's healthcare, travel, and banking applications. And so this also with patient access, this would also give the patient the ability to shop for care and manage costs. So they want to make sure that the patient is the payer of choice in healthcare by increasing the availability of data. So this is very important. And as we look into some of the details under HIPAA with patient access, some of this is covered where that the patient has the right to ask for the electronic copy of their data, of the PHI. And to have the provider electronically transmit the PHI to another person, as long as the patient has given explicit permission, okay? And also under the CMS, we want to look at, they want to promote the interoperability program, and it's a requirement for the providers. It will enable the patient to actually view, download, and transmit electronic health records, EHI, and access their choice of the third-party health apps using those APIs as was discussed earlier. And also the API, once some of the requirements for the developers who create some of these APIs, we want to offer the certification for API functions so the app can retrieve whole or partial patient records, and also be able to apply security measures within those APIs. All right, so with the HIPAA and Trust Exchange Framework, how will allow these health records to be transmitted? As you can see, as the image on the screen, there are various ways where patients can gain access to those digital health applications. And today we use a lot of those different devices, whether it's from a tablet or on your smart device, your smartphone or smart watch, or even your laptop. So these can be transmitted to these devices, and we want to make sure that the APIs that they use are interoperable and be used through different health applications to make it easier for them to be, for those applications to be created by healthcare entities at an easier, and also interoperable between healthcare applications. Also, we want to look at that by secure email, if requested by the individual, and direct messaging through healthcare information networks, that they are encrypted and the email is secure. And also through patient portals. We all know that most of us will log into a patient portal, and we want to make sure that those are available to the patient access, to gain access to their patient records through portals. And within these portals, they should have, they should be able to engage the patient with online scheduling, secure messaging, prescription refills, etc., through the patient portal. Now we're going to look at some of the information blocking, on the final rule for information blocking, and it applies to 3 categories. And the first category we're going to look at is, you will see that you hear a lot about, is the category of an actor. So you say, what is an actor? The actor is the healthcare provider. It's the health information network or health information exchange. And it's the health IT developer or certified health IT who creates the applications and those APIs. So when we look at this, we say, what makes an individual or entity an information blocker? So what makes them an information blocker, and also why they are called a blocker, is because they are undertaking the practice of like to interfere or prevent or materially discourage access to exchange or use of electronic EHI. And that would make them an information blocker. So elements of the information that is information blocking is that an actor is regulated by the information blocking provision. It involves health information EHI. The practice of information blocking is likely to interfere with access or exchange or use of EHI. And the requisite knowledge by the actor, and also if it's not required by law, will make them an information blocker. And then it's not covered by an exception, because there are some exceptions with the information blocking rule. Next slide, please. Also, providers are also part of information blocking, which far as we look at, information blocking is where a practice knows is unreasonable and is likely to interfere with, prevent, or materially discourage access exchange or the use of electronic information. So a provider can also be an information blocking. And we ask ourselves, who are the providers and who are they? And if we look at the list, we can see that these can be a hospital, skilled nursing facility, and so forth, healthcare clinics, pharmacies, laboratories, physicians, practitioners, and so forth. And then we look at the next category with information blocking, who could cause information blocking, is the HealthIT developers, those who create the APIs, the applications, who develops IT for its organization, who engages or who develops or offers health information technology and engages in the practice that is subject of an information blocking claim, one or more health IT modules that is certified under a program for voluntary certification of health information technology. So health IT developers are also in this category. Let's look at some examples of information blocking. The health system requires staff to obtain patient written consent before sharing the patient's EHI with an unaffiliated provider. This is an example of information blocking. Also, a hospital customizes its EHR to include barriers to sending referrals and EHI to unaffiliated providers. So that's where that health IT and the APIs come into question there. An EHR vendor prevents, this can be through high fees or third-party clinical decision support application, from writing EHI into their EHR. Could be considered as information blocking. And also in healthcare and IT, a vendor discourages customers from getting data integration capabilities from a third party, claiming it would have the same functionality soon, while such functionality are in early stages of development. So we see that could also cause information blocking. There are some exceptions in information blocking. And one of those is the security exception. So a lot of times practices will have to implement certain security provisions to secure EHI. So as long as the measures are specifically tailored to the security risk and implemented in a consistent and non-discriminatory manner, then that would be an exception that would fall up under the security exception. Then there's also the infeasibility exception. And then this is denying requests for EHI if fulfilling the request is objectively and verifiably infeasible. The next is the health IT performance. This is a security exception where making technology temporarily unavailable for maintenance or updates, because we know that technology, whether it's for security reasons, whether it's for an upgrade of the application, they would have to actually be taken offline for a period of time for the maintenance and the updates to be implemented within the application or technology. So these will fall up under security exceptions. And then some more exceptions to be continued, also here to continue on, is the preventing harm exception. So these practices that are reasonable, these are practices that are reasonable and necessary to prevent harm to a patient or another person, provided that certain conditions are met that could cause harm to the patient. And then there are also a privacy exception. This is where practices implement to protect the privacy of EHI based in privacy laws tailored to specific privacy risk. You will see this more under HIPAA. And that was a quick through presentation that I really went through very quickly, about 12 slides. If there's any questions, we can answer, or we can actually forward them to the correct personnel. Thank you.
Well, thank you so very much, Mr. Hunter, for all you do to protect the availability, confidentiality, and availability, integrity of the data and systems here at Morehouse School of Medicine, as well as the insights you shared in your presentation on how the regulations will impact clinicians and their patients. As mentioned earlier, it was designed to give patients greater access to be able to manage their healthcare more effectively, and also to make information more shareable by the providers with each other, different places of service. So this information is readily available for all clinicians and healthcare organizations. On the Office of the National Coordinator's website, they have a very extensive ONC Cures Act Final Rule FAQ sheet that provides more insights into how these different scenarios that exist in healthcare organizations will be impacted by the 21st Century Cures Information Blocking Rule. Next, let's see if there are any questions in the Q&A. I neglected that one last time. All right, I have a question. The blocking rules address many of the reasons for the lack of information sharing. What additional measures do we need to take to assure that information is shared? Today, we still have these silos. So any insights you can share on?
I think it really depends on the, when we do the research and we look deeply that the EHR, the actual applications that is built in through those APIs, because what we see is that the practices may not have the ability to share that information properly and to give those patients the access to that information. And when we look at it, may be that the EHR applications are not up to standard yet. So that could be part of the blocking that we see. And once we some of the applications that there has been a lot of pushback from those health IT providers from implementing, and a lot of it has been cost. And so that's an area where those APIs have to be developed to be able to share the patient access through different channels.
Thank you. That's an excellent perspective. I would like to go back just a tad to a question that came in regarding our presentation by Dr. Ozonic. And the question is, FHIR or FHIR was put forth as an interoperability solution years ago. And like other initiatives, we still have these siloed health information exchanges. Do we need additional federal legislations to encourage vendors and health systems to share their data? Or what is the solution to equitable exchange of patient information? I believe Dr. Ozonic is still with us.
So, you know, if you look at it, FHIR APIs, I mean, let's step back and just talk about APIs as a technology. Certainly it's proven on the internet. The internet commerce could not exist without it. And in addition, you know, it's a mature product. Now, the thing about fast healthcare interoperability resources is that it's, you know, been designed specifically for the use case of healthcare and frankly targeted toward the US CDI data elements. Will Yeah, we just did the survey of organizations, or we're in the process of writing it up right now. And what I'm surprised about is that the HIEs, the health information exchanges we interviewed, all know about APIs and FHIR. And they have projects. They're sort of building their own solution, right? It's not like being offered by a vendor. They're all sort of doing their own proprietary thing. But when we talk to provider organizations, they really were not up to speed on FHIR and APIs. So, I think what will probably have to happen, the way it will evolve, is that it will be introduced into the electronic health record and maybe somewhat transparent to the provider organization. They don't know whether it's coming through an HL7 message or through a FHIR API, but the migration will occur to the more efficient technology. But yeah, silos are a real problem. That second slide that we looked at just showed you the limited amount of data integration. So why be optimistic on FHIR? I was told an interesting statistic, and if I could just think of what it was the use of bulk FHIR. Bulk FHIR is the idea of doing automatic calls to organizations and automatically download the whole USCDI of every patient that you're going to be seeing in a given day, right? Automatic bulk FHIR access and download. And that's really been around, I think, 6 months and 9 months now, and it's been really adopted by some of the larger health systems, such as Harvard, some of the leading ones where normally you see the technological innovation. But I can understand skepticism. But you could have been equally skeptical about commerce on the internet, right? And APIs were used to solve that problem. There was a financial incentive. I think there's going to be the financial incentive of value-based care to basically get your full reimbursement or shared savings, or minimize your risk, your downside in terms of the contracts. So I think the financial incentives will be there, and at the same time, the technology will continue to evolve. APIs are well-known technology, but it could very well be they won't work. But I think that's not likely. I really think that if you've seen the success in internet commerce, it's hard to think why it should not be successful in healthcare. I don't know if that. I guess hope isn't a strategy, but we have to, right?
Yeah, so thank you so very much for that, because the goal is the equitable exchange of patient information, and money is a great driver of innovation. So we're hoping that the movement will kick it into high gear. So we'd like to encourage our audience members, if you have other questions, to please put them in the Q&A box. We'd love to hear your questions and address them as we go through our event today. Next, we'd like to give our attention to our policy and health information exchange experts to share what's happening in Georgia. Megan Douglas, JD, is an assistant professor here at Morehouse School of Medicine, and she's also the director of the Research and Policy Division within the National Center for Primary Care. Carmen Hughes is the director of the HealthIT Division, which includes Hybrid Solutions, Hybrid HIE, and our newest project, Aim Ahead. Please also welcome Liz Hansen. She has assisted literally thousands of providers to participate in state and federal incentive programs, such as Meaningful Use and the QPP MIPS programs. And through her partnership with Hybrid Solutions, she has done great work. She also serves as an advisor to the Georgia Health Information Network. And I'd really love for Megan to kick this session off. Let's hear from you first, please.
Well, thank you so much. Thanks for having me. Really excited to talk about this, and especially to talk about it with my friends Carmen and Liz. I will start out with just sharing some of the work that we've been doing in the National Center for Primary Care over really the last more than 10 years. We started looking at HealthIT and really in the policy space, recognizing the potential for technology to improve health outcomes and to reduce health disparities, but trying to make sure that the technology is realizing that potential, especially in the aspect or from the health equity lens. So a lot of our work, starting with looking at how high tech rolled out, and I know Carmen will talk a lot more even about this historically with the direct technical assistance that we'd been providing, but we saw that the primary care clinicians who were serving in small rural practices and serving lots of Medicaid patients were adopting electronic health records at slower rates than their peers serving in higher resource settings. We also were looking at telemedicine, and back 10 years ago, the utilization of telemedicine within the Medicaid program we found was incredibly low, primarily used for mental health services. So fast forward, we launched the Digital Health Tools Study in 2019 to look at whether any of those disparities that we had seen in adoption of digital health tools was closed, if any of those gaps were closing. Were we seeing more utilization? We knew that we would see more utilization of digital health tools, but really wanted to explore some of the use cases, and even thinking about digital health tools that are kind of on the rise. So we did the digital health tools study in Georgia, Kentucky, North Carolina, and Tennessee. This was a study funded by the United Health Foundation. And we started, like I said, in 2019, pre-COVID, expecting to be going out to all of these states and clinical sites and talking to people and learning about their experiences with technology. And then, of course, COVID had another idea for us. But we are looking at that and somewhat as an opportunity to. We added questions to our survey related to COVID, and then we also did focus groups with primary care clinicians, and had a lot of talking and discussion related to how COVID was affecting everything. So for our Georgia clinicians that participated in the digital health tool study, we found that more than 50%, 54% reported using telemedicine for the first time because of COVID. From our perspective, and based on the clinical settings and credentials of the individuals that were reporting first-time use of telemedicine, we think that the policies that were put into place and some of the necessity to shift gears into telemedicine did open up some opportunities for advancing equity related to telemedicine. So some of those very low utilization rates that we had observed 10 years ago in the Medicaid program, believed that there were more opportunities for people with Medicaid and people living in rural areas to access telemedicine due to the pandemic. Now, we also, I think it's important from the policy side too, that some of the policy changes due to COVID changed the geographic limitations for providing telemedicine services in the Medicare population, which also I think was a shift towards equity for telemedicine access. Now, I think some of the other highlights that we learned from the study that were not surprising. I think the more surprising pieces of this are that some of these barriers and challenges that we heard are the same barriers and challenges that we heard 10 years ago. So we heard a lot about how the digital divide is still affecting patient access to use of digital health tools. We heard from clinical settings about how they were developing workarounds. And I think that's one of the highlights is the innovation that we saw our clinical settings putting into place and taking advantage of during this very stressful and overwhelming time. Was really incredible to hear from them about having patients, drive to the clinic in the parking lot. The tablet would be brought out to them so they could do their telemedicine appointment using the Wi-Fi from the clinic. Things like that. And the top barriers to use of digital health tools for our survey participants were time, cost, and limited workflow integration. Again, things that we heard from 10 years ago. And because our focus in this study was primary care clinicians, and especially those serving in underserved settings, think that the limited workflow integration really being one about how do we make digital tools with the users in mind, both patients and the clinicians that are serving them, because that is still one of the biggest barriers. And then facilitators, we also wanted to hear about where it's working. Ease of workflow was actually one of the facilitators. So where there are tools that clinicians find easy to integrate into their workflows, they were reporting that as actually a facilitating factor. And then the other kind of interesting distinction between the barriers and facilitators, meeting patient need and improving patient health were on the facilitator side as the top 3 leading drivers. So definitely saw that clinician motivation to adopt when they could really align and make connections to improving their patient's health. And then just a couple connections from what I heard in some of the last session around the health information exchange, and had some interesting conversations with Carmen and Liz about this data point as well as we were preparing for this. But in our survey, we found that 70% of respondents said that they were connected to the state or local health information exchange, yet less than 40% of them reported actually using it. So I think another, workflow component that is really an important barrier to get over if we are going to see more exchange of health information across clinical settings and across clinicians. The last things I just want to, talking about from the Georgia level, what we're seeing in Georgia, but connecting that to the federal level, we really have been following the federal decisions around the public health emergency, which is currently set to end in mid-April, probably will be extended. But there are really significant implications for ending the public health emergency for Medicaid coverage that I think is really going to have a huge impact for patients or people in Georgia who were able to enroll for Medicaid and stay enrolled in their Medicaid coverage in ways that the program has not previously supported. So lots of people may be losing coverage, and that will be a big problem event that we will have to take into consideration. And then on the telemedicine side, even when the public health emergency ends, the fact that CMS has at least extended the telemedicine processes and policies that were adopted when the public health emergency started for another 5 months. So I think at least some preparation time for some of those changes that will come into place. And then we've seen a lot of movement or a lot of interest in Congress around what parts of those COVID provisions should stay in place, regardless of the public health pandemic, and what was working, what has worked, and what should be sustained versus what was an emergency fix due to the pandemic. Just want to end my part of this as really where our focus is with regard to innovation in primary care generally, related to the use of technology and digital tools, but also in finance and delivery of primary care, focusing on the equity implications and integrating health equity into all of those aspects, I think is where our focus definitely is now. And it's really been great to see kind of this unification of focus on health equity by organizations, the government, and I think this is really a huge opportunity for us to move health equity more into action over the next few years. So thank you.
Thank you, Megan. A lot to think about. And so we'd like to give our attention to Carmen Hughes next to share some insights with us. Carmen?
Awesome. Thank you, Phoebe. And Megan, every time I hear the stats or see the stats, I always learn something different. And what we're doing here in Georgia related to health IT policy. So it's interesting to see how things, to your point, will change once this emergency state ends. We certainly saw, and I think another panelist will talk about this a little bit later, but the increase of digital health tools over the last 2 years. So it'll be interesting. But before I jump into what we're doing now here within Highbridge and Health IT Division, I want to just sort of give a little context to tag on to what Gary and Megan talked about with just a bit of a twist, if you will. So I think, as we think about the HITECH Act, it really helped to boost supporting new technology and the workforce processes that Megan mentioned. But we also know that it added some additional, like telehealth, health information exchange, and what's also known as digital health. And so we hear that term quite a bit now. We didn't hear it maybe 10 years ago when the HITECH Act came out. But what does really digital health look like? But prior to the transition or transformation, I have to say, I would argue that healthcare delivery was really technologically inefficient. And that's me, with record keeping and care management and really kind of care coordination. The EHR technology early on helped physicians and clinicians to gather information in a certainly more advanced way. But we also need to improve health in the communities. Direct benefits of the EHR, of course, was operational efficiency, safety, and of course, improving systems of care. But now we know that healthcare providers and consumers have increasingly embraced more forms of digital health technologies in their everyday decisions. I, as a patient, go in with information presenting to my physician before they've even had a chance to diagnose me or to do a check. And I know that we all do that, and from fitness trackers to mobile applications, the tracking insulin administration. These digital tools really provide a wealth of valuable information to both the patient, consumer, and of course the clinician. But we've seen evidence that demonstrates consumers who are better informed to make their healthcare decisions are more efficient, and they take steps to improve their lifestyles through those applications, through the other digital health tools for often better outcomes. So we think about why we use it. Again, the digital health tools and health information technology is to reduce inefficiencies, improve access, reduce cost, and of course, better care coordination. But patients and consumers, they say, use digital health to better manage and track their health and wellness related activities. And of course, they're more involved in their care. I recently saw this article and was fascinated by it because it talked about, and we'll talk about this a little later as well, but it explored the current healthcare ecosystem and industry trends that are driving digital transformation and where this is headed. So, in every facet of the industry in healthcare is involved with digital health, including payers, providers, manufacturers. It's actually over $10 billion business. So there's new technology businesses breaking every day, as you mentioned, like the fintech and this related to healthcare and so many other services that are coming about. Solutions like the EHRs are advancing, digital therapeutics, telehealth, wearables, AI, and blockchain are really the foundation that's awakening in this industry. So it's important to know this, again, a driver for both healthcare provider and the consumers of healthcare. And I just want to kind of put that in context, because really the question for us is, what are we now doing here within Hybrid Solutions and the Health IT division to advance and assist providers with understanding the technology, understanding the rules and regulations around the technology, and increasing, hopefully, the quality of care and coordination of care within primary care. So our mission is we're focused on assisting clinicians in the redesign of healthcare delivery through the adoption of EHR technology and other interoperable systems. And I'm reading this verbatim, which the goal of optimizing patient information management is our goal for successful value-based care models and better health outcomes. So, Carmen, what does that mean? What do we do? And what are we here for? So we're here for the intent purpose of getting out in the community through various methods to educate, support, and lead healthcare providers through the rigorous requirements of CMS programs, such as the meaningful use. I've heard meaning less use. I've heard various terms, promoting interoperability, of course, the MACRA and the MIPS, to ensure maximum participation, increase care delivery, advance health equity among patients. So much of this work is done through the NCPC, as Dr. Mack mentioned earlier, as well as through our community partners and funders throughout the state of Georgia, and then of course beyond. But through the work we have done in the Regional Extension Center here at Morehouse School of Medicine in Highbridge, we've supported over 5,000 eligible clinicians in Medicare and the Medicaid EHR incentive programs from 2010 to 2011. And we're presently working with nearly 3,000 eligible clinicians through our work with supporting eligible clinicians in small, underserved, and rural practices in the MACRA and MIPS program. So there are a few data points I'd like to share with you specifically around EHR adoption and interoperability. So nationally, over 98% of all hospitals and 78% of critical access in rural hospitals have demonstrated meaningful use or adopted, implemented, or upgraded AIU, the EHR technology. And that's nationally, and this is CMS data. But specifically in Georgia, we have about 99% have demonstrated meaningful use or AIU of EHR technology. So this led to, specifically on the Medicaid side, over $14 billion across the state. And nationally, 211,000 eligible professionals and $7 million across Medicaid EHR program participants. But in Georgia, specifically for the providers, it brought in with the incentive payments were around $295 million to almost 11,000 Medicaid providers over the course of that 10 years. So when you think about that, Georgia combined Medicare and Medicaid, again, through the EHR incentive program, brought in over $1 billion in the EHR incentive program between 2010 and 2021. That would be great in 1 year, right? 2010 to 2021. So these are dollars that CMS and the Department of Community Health, the state here in Georgia, put back into the community for increased patient care through the use of technology and promoting interoperability. So for those of us who've gone through that journey with providers, when we hear those numbers, it really helps us to have some resolve in the work that we've done. And I know Liz is shaking her head as she was right in the middle of that, and Phoebe and our teams are right in the middle of that over this year. But when you think about those numbers and those dollars going back into the community to support interoperability, it brings some resolve and some gratification, and it helps us to also keep moving forward and encourage our clinicians and physicians to keep moving forward as they work through the strenuous requirements and also the value-based care payment models. But the Medicaid EHR program, as we know, has ended. But on the Medicare side, there is the MACRA Quality Payment Program, which has two tracks. And then most of the Georgia participants are on the MIPS track, the Merit-Based Incentive Payment System track. And again, because interoperability is critical, one of the 4 components in the program is promoting interoperability, which has consistently carried a weight of 25% of the clinician's total score. It now covers areas such as e-prescribing, health information exchange, to include referrals and bidirectional data, patient portals, and access to public registries. And so we do continue to support clinicians in this area as well. Now, I also want to quickly mention at the interoperability work being done through our HIE, Health Information Exchange, which is called HiBridge, HIE, connecting to our state designated entity, which is GHIN, Georgia Health Information Network. HiBridge was created to support the smaller practices and hospitals in the everyday use of electronic exchange at the point of care, patient exchange. We're able to connect with any facility and any EHR platform. So we're vendor agnostic when it comes to the EHR technology. So I'd like to say in the big picture, the Health Information Network is really the super highway of patient data exchange with the goal of having the right information for the right patient at the right time. I borrowed that, but I like to say it, so I'll claim it as well. The interoperability goal is ultimately to improve the healthcare quality, avoid costly mistakes, reduce related costs, redundancy, et cetera, and again, to help coordinate better care. So as we look into the future, and I think each presenter's really talked about that, as we look into the future of interoperability for healthcare, we know that clinicians and patients and stakeholders are key for the engagement. And we know the technology, well, they will support the technology that's going forward, that it's really interrelated and interdependent. So I want to just stop there for time. And I want to turn it over to Liz Hansen, who is for us an incredible resource in the space with HiBridge and has worked with practices, as Phoebe mentioned, and clinicians for some time now. Liz is, I would say, definitely on the front line and boots on the ground. So Liz, I will turn it over to you to carry the baton. But you have to do it when you're not on mute, though.
Thank you. Thank you, Carmen, and thank you. Thankfully, I like having my boots on the ground, so that works pretty good for me. Appreciate being able to join everyone today to talk about what's been happening in Georgia and what we hope to happen. As you heard from Carmen and Megan, we've been working really hard in Georgia since 2009, I think is when we actually got going on it, to make our health system, our providers, able to keep up with HIT regulations while improving quality of care and health. And those seem like they go right in together, but we find they don't necessarily go as smoothly as we like. Our health systems, our clinics, our larger practices, I don't doubt that they are right in with the numbers that Megan saw in her study, and that what I think 70%, yeah, I could believe that they are connected. But we focus on small practices, small, underserved, and rural practices, those 15 and fewer. And I can promise you 70 is not the number they're seeing. And so that's one of the things that we want to talk about, we want to work on. The FQHCs, the regional health centers, the rural health centers, the critical access hospitals, they've been able to utilize some federal funding very effectively and have been able to stay up. I have to tell you that all the health systems and these FQHCs and these types of organizations have just amazed me with how agile they have been. Every year we see new rules and every year we make adjustments. So that's been amazing. But the problem is that we don't have that agility in the small practice. We don't have the funds in the small practice, yet the small practice is a major piece of our healthcare environment. So we need to think about it because our smaller practices are struggling. They've struggled for 6 years with meaningful use. I know Carmen took my meaningful useless term, but we also had meaningless use, and we had many terms that were used. I say we, I'm talking about my providers. They fed this to me. 5 years of QPP, 6 years now into QPP. These providers struggle with information blocking, interoperability, HIPAA, maximizing their EHRs, trying to get out of their EHRs what they paid to get so they can make good enough scores to get a reimbursement. And it's quite a mess right now. They see they've made this huge investment in time and money in the EHRs. Every year they're waiting, 3 to 5 months or more to get their EHRs to catch up with what the regulations are for this year. It's frustrating. Oh, and in addition to that, practices have to sustain, right? And they might want to practice medicine every now and then. So there's a lot going on. I don't want you to get as concerned as I am, because most of those providers are totally oblivious to how bad it is. I mean, so when I say it's struggling, I know they're struggling. They may not have figured that out yet, but that payment program is 2 years behind. And I think we're going to see some discomfort coming. Luckily, that's a weird word to use, prefacing COVID, but that gave us a buy that many providers absolutely needed. And I would wish for just one more year of that, but not for the COVID extension, just for them not having to report this year. For many small, underserved and rural practices, we see over 80% of providers using EHRs. Back when the EHRs were first introduced, yeah, I was there. Back when EHRs were first introduced, boy, those first 5 years, maybe 10 years, we couldn't get past 5%. So 80% is outstanding. But what we're finding is very few are using those resources, those tools, that EHR, EMR effectively. They're certainly not using it to their potential. And they don't really understand the benefits of doing so. They're not seeing it. Only a very few, and we have some outstanding providers in our state, like Dr. White, who are actually using their technology to improve the health of their community. Wow, folks, that gives me chills, because that's really what we want them to be. And I could name you maybe 4 providers in the whole state doing that. So at the practice level, so that we'd like to move that forward, and we'd like to take those folks that are doing such a great job and teach the other providers how to do it without totally halting their practices. So we have to be careful, but we know what can be done, and boy, is it sweet. One of our problems is the providers can't see the pleasure through the pain. They know that it costs more money. They know they have to do more clicks. They think it takes them more time. Pain. So we need to give them a reason to believe. That's what we need to do. There's a song about that. And patients, wow, they've really stepped up to their game in Georgia in utilizing healthcare technology through patient portals. And I say they've really stepped up. Is it 100%? No, it's not 100%. But we've gone from below 5% when, well, there weren't even patient portals in 2010, so forget that. But once we started implementing patient portals, we went from 5% up to, we're probably over 70% in most practices now. And that's just in the last 5 years. I know I had a provider tell me about 4 years ago, if he could just figure out a way to sell something on his portal, he was sure that every one of his patients would log in. I didn't encourage that. Maybe if he was a dermatologist, I would have. I didn't encourage that, but providers were frustrated because they couldn't get their patients to get on the portal, yet they were getting dinged for it if they couldn't get it done in quality payment program and meaningful use. So we actually think COVID helped that and got more folks to want to get on a patient portal and find out, rather than waiting on a line for 4 hours to get a response from a practice with short staff. Also, federal requirements, meaningful use and quality payment program made a major difference in folks pushing, for providers pushing for portals to be used. But what has happened is it has gained so much momentum that patients are just all over it. Once patients realized what they could accomplish, how quickly they could accomplish it without as much frustration, they were all in. And they may not know what FHIR is. Most of them do not. Most of my providers do not. They may not know what FHIR is, but they know how to use mobile apps. Okay, so if you give them a vehicle to access their data and make it better for them, and it's something they're used to doing, we've got action going. We need to do that for the providers with accessing information and utilizing their systems. We need to get us to a herd mentality on some of these other efforts like health information exchange. Before I move on from patient engagement, through technology, I do need to mention a couple of the things about that. Patients have not bought into in my opinion, or in Georgia, patients have not bought into checking the physician compare site, which is where CMS posts provider scores for the quality payment program, with the concept being that patients can look on there and see what patients have good quality scores and make a decision about what provider they want to use. I could do a whole session on what might concern me about that, but that is for another day. But patients aren't using it. Okay, they're not using it. They don't know about it. The providers don't know about it, and they don't care yet. Okay, so maybe that'll change, and maybe it'll be in Angie's list. But right now, and I'm glad of it, that's not really being used. So good try, CMS, might be a little before its time. The other thing is information blocking. There have only to date, a couple of weeks ago, there have only been less than 300 information blocking complaints nationally. Okay, so that's really not many complaints. Now, granted, 64% of those were made by patients, but that was only 174 complaints. So nationally, so that really doesn't put too much emphasis on that. If you were a man in the streets and you stopped and asked patients about information blocking, what we're finding is the ones that are complaining or turning in complaints are very similar to the folks that turn in HIPAA complaints. They are people who are employed in the healthcare industry, so they know the rules. We're not seeing your everyday work outside of the healthcare industry people have a clue about information blocking. So while it is critical, let's not panic patients about it, which is almost what it feels like media-wise, that we're emphasizing something that patients really aren't concerned about. And what we really need to do is just educate them. Now, most of my providers are clueless about, and these are small practices, okay? They got other things going on, but they're clueless about information blocking requirements as well. Thankfully, most of them have EHRs with portals that are tracking, and their systems are tracking the promote interoperability requirements and also the open records requirements. And so it happens transparently to the provider, so it doesn't hurt. Now, it hurts a little bit that they got to get their records signed within 3 days, but once we get them over that hump, they do pretty good, and they can sign off in a timely manner. And then they don't even know that they're not doing information blocking. They just know they don't have to worry about it. And that's a place to be. Okay, that's low stress, high success. So that's where we need to be. So we want to continue to encourage that. Now, I mentioned earlier that the large organizations, health organizations, are being very successful in keeping up and in participating, handling their own interoperability and information exchange. What I didn't mention, and although some of our other speakers have, is they're doing it in silos, okay? They're doing it with their health system, often a very closed health system, and I understand that. There's control issues, there's trust issues, there's legitimate reasons why folks should be concerned, but it's stifling our ability to push past the bubble and be successful with health information exchange and what it gives us. So rather than hoarding information and trying to be siloed, we need our health systems to reach out and help us connect instead of just trying to have their own silos that work just fine. Because sooner or later, I hope the government's going to make you do it. Of course, you know, the state of North Carolina spent hundreds of millions of dollars and made it a requirement that everybody be attached to be connected to the HIE. And they pushed that back 3 times now. And I think it's now postponed until next year. So even if you got, $500 million, it's not the easiest thing in the world. But if you gave it to us now, we are ready. So if somebody's got it and wants to let us have it, we're all in. But just imagine if a provider didn't have to log into multiple hospitals in the Atlanta area to check on their patients. That's pretty big. An HIE would resolve that. Not just an HIE or connection to one hospital, all the hospitals. Knowing what if ED knew who the PCP was, the primary care provider. So they assigned it to somebody. So somebody followed up. So maybe that patient didn't show back up in 6 days. That would be helpful. And that could be resolved through HIE. Automatic and immediate alerts for discharges, admissions, transmits, not having to key in meds, reordering labs. I know everybody's been talking about this already. Multiple registry portals. Seriously, I could go on, but I need help. We need help in convincing providers that this is going to help them be more productive, help their patients be more healthy, and be better off, lower costs for our health system. But the information has to be shared. So that's why we're pushing the use of HIEs. Our practices need help. We need to act as a village to raise healthcare through technology, and the village is Georgia. We'd love your help. Thanks.
All right. We are have received a very excited call to action. Let's get it done. So we thank you so very much for basically expanding on the policy side for Megan and the technical infrastructure that's required to support this innovations in healthcare. You know, we need it in order to coordinate care delivery. So we thank you for sharing your insights and your experience working one-on-one with the providers, and for what's happening on the policy front, and also what Hybrid Solutions and Hybrid HIE is doing to contribute to the success and the removal of these barriers so that information can flow more freely. So our next session, I'm really looking forward to this. And Carmen Hughes will serve as the moderator for our panel discussion. And we've chosen a title that's interesting: HealthIT, Best Friend or Foe to Successful Clinical Care. So Carmen, we look forward to you leading this panel discussion, and the diverse panel that you've assembled is sure to be extraordinarily engaging. So we'll turn it over to you.
Fantastic. Thank you. Thank you. And Liz, yes, I think we're going to have you go before the state legislator here in Georgia. That may be your next assignment, to make sure that potentially that, you know, providers have some type of requirement for interoperability and health information exchange. So we'll add that to the list. I know it's been pushed by several folks, so we'll make sure that happens. But I am so excited about our esteemed group of panelists today. I think everybody's on. I know we actually have one clinical provider who may be, who's actually delivering patient care at the moment. Ginger's here, awesome, thank you. So we have 4 subject matter experts in technology from 4 different areas of IT, health IT, assembled, who are going to share from their lens. So let's get started. I'm not sure how your Zoom boxes are looking, but I'll go for mine. We have Mr. Amin Holmes, who's the co-founder and lead engineer of SensorMed, a digital health tools company. We have Ms. Ginger Irabedra, a practicing nurse practitioner with Dr. Kim's internal medicine practice in Cartersville, Georgia. Ginger has eagerly embraced technology in her patient care delivery. We have Dr. Angelita Howard, Assistant Dean for Online Education and Expanded Programs here at Morehouse School of Medicine, and a driving force for MSM's Masters in Health Informatics program. We have Dr. Mohammed Idris, a professor here at Morehouse School of Medicine with a passion for artificial intelligence and machine learning. So again, we have an esteemed group of panelists, and I'm so excited, and thank you, each of you, for agreeing to share your wisdom and knowledge and experience with us. So let's get right to it. Ready? We said this was going to be fast and rapid fire. So the first question is going to be really for all of our panelists. And as you respond, we'd love for you to tell us a little bit more about yourself and your role in Health IT. So the first question is, because we have a very diverse group of panelists and subject matter subject matter experts assembled here. We want to start the conversation by asking, when you think about the educational, technical, and clinical aspects of health information technology, how do you individually think that we can support the convergence of these areas and bridge the gap in health IT? So, Mr. Holmes, I'll start with you.
Okay, sure, no problem. Thank you, Carmen. I appreciate the introduction, and I've enjoyed all of the content on the program so far. So thank you for having me today. So the question about how can we support that convergence, I see a lot in industry, a lot are moved by metrics. So typically people don't move and adopt things unless there's some statistical significance around the outcomes, the benefits, and you can quantify things. So the first thing that came to my mind about convergence and supporting that convergence is really participating in more surveys. When we ask patients to actually participate when someone calls them and asks their opinion, to actually speak up about it, because the more they participate in these things, the more numbers we can get about how great technology is and how it's health outcomes. And so then that's going to drive more and more adoption and lead. So it's kind of a cycle that feeds on itself. So I would just, I try to encourage patients to participate and have their voices heard so that everyone can know about the benefits of technology.
Thank you. Dr. Mohammed Idris.
Thank you so much for having me. As I was thinking about an answer to this question, I was trying to go back and think through my various experiences in academic research, in industry, in the startup space, and even as a student. And I think one of the things that I've come to learn, over the course of all of those experiences is that we often talk about technology and innovation as a solution and an end in and of itself. Whereas I found it's actually most effective to really, have conversations with people, right? To ask them what their problems are, to really empathize before even thinking about technology as a solution. And I think in that way, people don't necessarily have, blinders up to where when they hear AI and ML, they think, oh, it's going to replace my job, right? When we think about, we need to change how clinicians are trained, right? It's not like, this is yet another thing that I need to be thinking about, and am I prepared for this field, whatever it may be. And so, I guess to kind of sum it all up, I think the first step is kind of a conversation, identifying the appropriate problems, use cases, and I think that will at least put us in a place where folks start thinking of themselves as being empowered by technology, right, versus it being an administrative and other types of burdens.
I like that. I think that's both on the consumer side. My phone never rings. That's the beauty of, of live events. My phone never rings. But I think that's from a standpoint of both the consumer, patient, as well as the clinical provider. So speaking of clinicians, Ms. Irabedra, what do you think? How would you think that we can bridge that gap?
Well, as I've been watching some of the symposium, I realized that as a clinician, I do sort of feel like an outsider to all of this that's being spoken about. I've only just begun to learn about this after becoming licensed, after starting practice. And so really, I'm not sure exactly how to add that to the clinical education that we go through, but it has to be done. Somehow, we've got to learn more about this before we hit the ground running, because once we hit the ground running, taking that time to learn the EHR and to learn how to use it becomes much, much more challenging. And I think just society-wise, our younger children, they don't think about data integration. They start at kindergarten, like they're using data and integrating it and looking for things from the beginning. So we're still a generation that is transitioning into, we come from, some of us from the typewriter era, and now we're trying to use data integration. So we're in a significant transition when it comes to technology. And the exciting thing is, I think as the younger generation moves on, it will just be a part of what they do. It won't be as, hopefully, as challenging as trying to get the older generation to stop paper charting, stop faxing, and actually use the data.
Thank you. And you're right. I mean, we often find that we can reach physicians and clinicians by faxing. And that's so difficult for us to think about because that's not what we do every day. And how do we change that dynamic? So thank you for sharing that. Dr. Howard, you have a unique perspective on our panel.
Yeah, so, you know, I would certainly merge or marry what Ginger and Mohammed said. As an educator, that's exactly what we have to do. We've got to educate, train, but with industry or with the workforce in mind. So there is an alignment that has to happen that is not necessarily happening before maybe students graduate or as a part of their matriculation, that they're really working. We think about, you know, internships, we think about how does that work, but are they really getting the information? Then so that Ginger, as she mentioned, she wouldn't have that gap. There wouldn't be that gap because some of that information would have been told or explained, or she would have gone through some of those things. And, you know, different educational programs, you can't get everything all the time. I mean, you just cannot. But essential to what we're doing in the workplace and HealthIT, I think there is an opportunity for us to really think about in education space, how do we work with clinicians? How do we work with industry, workforce to make sure that they are helping us align what should be taught, what should be given and provided to those students so that the gaps are narrowed, and then students know how to narrow gaps in their clinical settings or in their work settings as, you know, HealthIT in that space.
So, please.
I was just going to add one thing to the point about education. I think more importantly, I mean, the pace at which technology changes is so fast that by the time even our kids are there, they're probably going to have their own version of it. And so I just want to emphasize just the continuing education component and conferences and workshops like this, where, I mean, listen, I could build a lot of things, but I don't, you know, there's a lot of things that I don't know, right? And so having opportunities for continuing education, in particular, I think kind of intimate environments like this. I mean, I again applaud the organizers, Carmen, Dr. Mack, everyone. It's been fantastic.
Well, thank you. So I want to follow that same on that same line of train of thought that we have going on. And so, Dr. Howard, you know, as we've said, your area of expertise is workforce development. And so can you tell us a little bit about what health informatics is and how the learners are being trained, if you will, to assist in primary care delivery?
So I'm going to give a textbook definition of health informatics. You know, we hear about health informatics, we see it. I'll kind of give a textbook, and then I'll give my radio version of it. So, you know, health informatics, it uses information technology to organize and analyze health records to improve ultimately the patient outcomes. Informatics, it helps physicians have easier access to patient information, and it also helps them with decisions, informed decisions. So in technical or lay terms, then I would say, when we think about health technology, when you go to the doctor and you see them on their computer, they're sending labs, or they are sending prescriptions over, you know, that's all a part of health technology. When you are making sure that you can see your records online, that is health technology. When you're able to now Zoom your physician or your healthcare provider and get your prescription, you know, all that's a part of health technology. And then COVID, we've seen all of these numbers, rates, and all of these things happen. So what we've done, even at Morehouse School of Medicine, is we're building information technology, health informatics programs from a certificate level to a master's level to really integrate this. We understand, especially in minority communities, that it's a huge diversity gap. And so what we know and what we've seen is that we've got to help send more people out. So we've built programs that do just that. And we're working, again, I mentioned earlier about alignment with industry. We're working with industry to make sure that there is alignment there, to make sure that students, as technology changes, we're keeping up, we're trying to keep up as much as we can by having these partners to help us know what's happening in the workforce, what's happening in the workplace. Can you work with our students to make sure they're getting the latest? Again, Muhammad said, we don't always know because there's so much happening, but that's why it's important for us to have those industry relationships, have those workforce relationships so that we can stay at least in line with what's taking place outside for our students.
So thank you for that. And I think, as we think about going back to the clinician, Ms. Irabedra, what would you say would be the most important component of your data gathering and how within your EHR, within your electronic health record system? What would you say are some of the key factors and things that you look for so that to help with your patient care?
So probably hands down is being able to accumulate that data and allow us to see trends over time. So, under paper charts, we would have to flip through and see, well, what was this then? What was this then? And now with the EHR, you can click a button and you can see, that their, kidney function, while in initial, when you first pop it up, it might look, okay. But if you look at the trends and you think, well, Lord, it's fine now, but it's going down. It allows you to intervene before something actually becomes abnormal. So I would say hand down, the first thing is just being able to track trends over time. Second of all would be when you're managing chronic diseases, and there's all these little bullet points that you need to be getting. For diabetics, you need to have foot exams done. You need to have microalbumins done. There's just numerous things, and just other things that you want to do at different age points. Trying to sit down within the 2 minutes before a visit and see if you've got all those things checked off. It would be nearly impossible without the electronic health record to kind of put it together and show you where those gaps are so that you can get the gaps filled. So those two things are probably the most important thing that the EHR does for me on a daily basis.
That's great. So then I'm going to take it even further and ask Mr. Holmes, as we think about other digital health tools that integrate with the EHR and specifically around telehealth, telemedicine, and remote patient monitoring, sort of how, when you think about those areas, and I'm assuming they fall into digital health tools, right? So how have you seen that improve or not patient care delivery between the patients and the providers?
Well, a few different ways. So specifically on the patient side, so here at Symposium, we specialize on remote patient monitoring. So a few things that we've seen are the patient has a stronger connection with the provider, because instead of, let's just say you go in January and then you don't come back, you don't have another appointment until June. Well, typically you don't know what's going on with the patient in between that time. But using different devices and the internet, you're able to have some type of link with your provider. Now you can send your blood pressure in, your glucose levels, your pulse ox levels on a consistent basis and feel like you have a stronger connection with your provider office. So patients have commented that they feel like someone's watching after them. They have a kind of safety net, if you will, from the provider's office. Whereas before, it's kind of like unless they get an ED visit, the provider doesn't know what's going on with them. So this technology really helps with that. So that's one way. And also, I think it also gives patients more confidence because of their knowledge about their own situation, about their own numbers. So again, some patients may not know their blood pressure until they go to the doctor's office, 3-4 months later. Well, now with these devices, they're able to know their own pressure every day. And so they're armed with their own knowledge now. So that incentivizes them to take a be more invested in their own health, to take more action for themselves, and not just say, well, it's the doctor's blood pressure reading. They did it, right? It's like, no, I'm doing it for myself. So that sense of ownership, I believe, gives them more confidence about their situation and how they can make themselves better. On the clinical side, for insurance companies, reduce ED visits, reducing the overall cost of healthcare. These type of technologies have helped with that. So hopefully catching things before they get too bad. So that's one of the main goals on the clinical side of the digital health tools that we deploy, as well as faster recognition if a patient is treatment resistant to a particular medication. So I've done this with my own mom, actually, is that, she was given blood pressure medication and it just wasn't working. And she wouldn't really know that, but I was taking her pressure 3 times a day. And I'm like, this is not budging. Like, so after a week of it, I'm like, we need to call the doctor because it's not budging at all. And so they gave her another medication, didn't budge. But finally, the third one, we started to see some difference. And so now, how long would that take if she wasn't measuring her blood pressure every day? So these type of things really go to help, the overall system and reduce the cost of healthcare. Because again, if she didn't have that information, would it end in a stroke, heart attack, something else? Who knows? Because she would have been taking the same medication and not knowing if it was helping her or not. So those are just a few ways that it has an effect on the patients, as well as helps the system, insurance companies, providers alike.
Well, thank you. And that certainly aligns with some of the earlier conversation as well, with patients being empowered and using tools in different ways and understanding, have a better relationship with their providers because they are empowered with knowledge regarding their healthcare. So I think, when we think about artificial intelligence and machine learning, we all use it in some way, whether it be healthcare or otherwise, and don't really think about it. When we open our email, there's something in there around AI. So Dr. Idris, when you think about AI specifically, can you tell me what impact does it have on patients and clinicians, and some illustrations of how it's currently being used, maybe some common things that we hadn't even thought about?
Yeah, sure. No, it's excellent question. I think, for example, whenever I'm teaching what is AI and machine learning, the quintessential example I always give is spam, right? So you get a lot of emails, there's specific features within that email that we can categorize as being spam, and then you develop a model that over time is able to recognize and adapt and things like that, right? And so really there are so many different use cases across healthcare, and whether that be on the administrative side of things, so on billing, scheduling, so on and so forth. And where I get a little bit more excited is really more on the clinical applications, and that spans diagnosis, prognosis, and treatment. And so I wrote a few notes here in terms of trying to provide some very specific examples that I think, at least to me, kind of illustrate the breadth of opportunity. Now we could talk a little bit further about, okay, is this actually being used and how far are we from it being ubiquitous? But I think really, at least in my mind, what I get excited about is really thinking about the possibility. And so a first example, the one that people often talk about, is helping radiologists review images and other scans, right? And so you could imagine, there are a variety of different types of clinicians who have to make judgments based off of their kind of experience and expertise as to whether or not there is some, irregularity, let's say in a scan. And there actually is quite a bit of, there's statistics around how kind of a failure to identify and treat patients early on can be very difficult, right? And so we have these massive databases of actual, we would call them training data sets, right? Where clinicians have actually said, yes, there is this part of the image. No, there isn't anything within this image. And then after that, we have some sort of an outcome, right? So whether or not something was identified and treated and led to a good outcome, right? Or if it was, let's say, a false positive. So again, just like in that spam example, these are all data that we could then use to kind of train a statistical model to be able to look at pixels, and in that being able to come up with a prediction as to whether or not there is an irregularity in that image. Another example is diagnosing, early stage chronic diseases. So for example, when we think about acute kidney injuries, being able to identify these things early on, or early stages of heart failure, right? Just opens up the possibilities in terms of the types of interventions that are available. As Ginger mentioned, right? Just being able to know, given a particular patient and their kind of unique circumstances, what the prognosis or the trend might look like, again, might provide insights to be able to think about what should I be doing today. Another one that I thought was really, really interesting, because we've seen it, kind of come time and time again, is really the ability to predict from databases. So for example, so the USD, so we have, all of these medications that have been approved for a very specific condition, right? And trying to repurpose them for other conditions or issues. So for example, for COVID-19, our ability to make sense of these massive databases, to do molecular simulations, to do some of this AI and machine learning that will allow us to identify potential targets, again, is a way of speeding up drug discovery. And that's not new. That's been happening for a while. And then the last one that I want to mention, that to me, because, as I'm thinking about all of these things, I'm always thinking about it through the lens of equity, right? How do we address health disparities? Whereas I have a thesis that I'm working on, that if we don't do it through a lens of equity, you're going to have a disproportionate impact, and you're actually going to, certain groups are going to benefit, others are not. And so therefore, that's going to lead to inequality. But really thinking about how we can leverage data in order to identify social determinants of health, and also provide recommendations on how to address them at scale. So for example, we have massive open data sets, whether it be from the census, from the EPA, right? That give us a little bit of information about how an individual living in a particular community, their health might be impacted by their environment, right? And so being able to do that at point of care is amazing, right? And actually our tools, there's a company out there that Grady actually works with, where given just the zip code, they can give you potential social and structural determinants of health that you should screen for, but then also recommendations in terms of what those interventions might look like. And I think, again, that opens up a whole new world of being able to identify tailored interventions for individuals, and having an EHR system, wearable devices, being able to collect and analyze this data, I think just sets us up to be able to kind of take advantage of these possibilities.
Thank you. And, that goes back to something I think it was Liz talked about, using the data that we receive in support of the community, not just a single patient itself, but the community overall. When you talk about the social determinants of health. And so again, looking at AI, machine learning, there are certainly there's certain synergies that are needed to be able to reduce health equity, reduce health disparities and improve health equity, because that's the lens that we look through in all that we do, is improving health equity. So thank you for mentioning that and sharing that. So I want to go back to Ginger a bit, and we talked a little bit about your EHR technology. And have you had the opportunity to implement other digital health tools, such as remote patient monitoring? And if so, what have you seen from that? What are the successes? And if you haven't, potentially, are there reasons why you have not yet within your practice?
So in my practice, we still have kind of archaic remote patient monitoring. So, in my practice, I give my patient, for example, blood pressure, a piece of paper with, a chart on it. And it's go home, please. I need you to check your blood pressure. It may be every day, depending upon how high it is. It may be every other day. It may be once a week, for just that very reason, that if I don't see them for 3 to 6 months, or if I've made a medication change, I can't go 3 months without knowing if this medicine is working. And so by them taking it, and we have this detailed conversation that, if you're getting a number over 140, if you're getting a number on the bottom over 90, I need a call back to the office so that I can actually make a change, or I need you to schedule to come back in. It does put a lot back on the patients to do that. Do I have patients who do not follow through and don't bring? Yes. Do I have some that do? And I'm so excited when I see them pull that piece of paper out and show me, because then if nothing else, I have a way of, documenting that this is working. would love it if we had, if they have their blood pressure cuffs at home. It would be great if that could just integrate straight into the EHR and it could alert me or something. But we don't have that capability. Some of my patients have glucose monitoring devices where they can check their blood sugar much easier, and they can come in, they can bring me the little device and I can kind of thumb through it and see what we've had. And so we can talk about, well, what happened here? You were 270, and it opens up that conversation. We have a long way to go when it comes to what happens from this appointment date to the next appointment date, all the stuff that goes on in between. We have a long way to go to improve that.
Thanks, and you all are welcome to chime in on any of the questions, and not just specific. Specifically, I don't know if you have any feedback on that, just from your experience and the provider themselves transitioning from a more manual process to a more advanced way of monitoring and tracking in between patient visits.
Yeah, I think that the practices that have the most success are similar in that way. They already send patients home. So it sounded great that you already have like a sheet, a chart of something that you give the patients so they can take. But just like some patients bring it back, some patients don't. Same thing with the wireless technology. Some people use it. It's just some people, it just sits on the kitchen counter. But the thing is that with the newer technologies, if it's sitting on the counter, you know if they're using it or not, if it's high, or not. So I think that's the time difference, and the frequency, the cadence is much different in that regard. But I think the mindset of the practices that are most successful with the RPM programs are like your practice, where you're already putting the expectation in the patient's head that they need to do something for themselves at home. This is not just come to me and I'm going to fix you. This is, okay, you have a part in this too. We're in this together. Here's this pad, take it home. And so it's just the fact that you're setting that mindset. Those practices typically have a high compliance rate with their patients because that they're already trained as from coming there for years, that there's an expectation of work on their end. So I would say it's already a good start.
Yeah, I like that because it goes back, as an educator to education, and how do you start off educating your patient? Literacy, how do you, from the time they first walk in, here is what we're going to do before even a diagnosis is made. This is how we operate. This is our method of operation, so that you are a partner in your health outcomes. You are going to participate, instead of going to the emergency room, you're going to participate in how we treat you, how you're treated together, so that not only not only the healthcare provider, but that you as a patient, you can see, you can monitor, you can track. And so I believe that, that starts early on. It starts in initial visits. It starts with a part of how do we train, because even at 40, 50, 60, there's training that has to be done. There is education. They have to, it's like teaching that has to be done of how do you help be accountable for taking your medicine, for, checking your blood pressure at 4 p.m., checking it at 8 p.m., checking it after, you've done something strenuous, but that you become a partner in, a buyer in your healthier outcomes, if you want to keep living.
I love it. And I certainly see a great theme here going around patient empowerment around their data. And that's so important in their health. So I think, we're along the same line, really, when we think about the data, Dr. Howard, and we've talked about the data going into the EHR, whether it be, data from the clinician inputting it, whether it be patient data coming in. How do you think about, and we know that it's only as good as the patient data that's in the system to make clinical decisions. How are your students trained through their processes of education to be able to understand the data that's needed for clinical decision making and help in primary care and help the physicians?
Yeah, so, the training, again, we are intentional in making sure the people that we have to teach are clinicians, are CIOs, are people who are in the space. And oftentimes, when you have people that are in the space on a daily basis, then they are seeing. And so we perform, if you will, simulations. We have simulations so that students can look at data, so they can pull down certain data sets, so that they can analyze certain data sets. They can look at, the integrity of the data. How do you maintain data? What does it look like to maintain this data? And I always go back again, because of where we are at Morehouse School of Medicine, when we think about bias, as we look at, gender, as we look at different quantifications or quantifiers of the data, and how do you use that for patient outcomes? And so again, there's that intentionality. We have to be intentional as to what we're teaching the students when we look at clinical decision support, when we look at consumer digital health, when we look at, just the courses that we teach, thinking who are some of the best or key players in these fields, in these roles. When we look at even, we start off, and let me back up, we start off with a clinical operations and thinking communication, because just because you're studying this does not, especially in health IT, there are people who come from the IT space that may not know much about health IT. And so we start off with this basic, this clinical operations and thinking. There's an introduction to clinical terminology. There is an introduction to, what does it really mean? How the data sets differ? What are some of the common denominators? Who are some of the key players, healthcare providers, nurses, PAs, physicians? What does that look like, even from a public health standpoint? And then we use that to build their foundational knowledge of what something should look like. And then they go from there, they move on through a process to really understand how to use data for healthier patient outcomes.
Thank you. Any other thoughts on that? I appreciate the feedback. And Dr. Howard, let me just ask you this a little bit off script, but you mentioned public health and with health informatics, and so we know with COVID over the last 20 months or so now, almost 24 months actually, yeah. The importance of having accurate COVID data, whether it be vaccines or testing information available, as well as it aligns with even chronic care management. Have you had to change criteria, adjust criteria a bit within your educational forum?
So, we look at a lot of what's going on through articles, through newscasting, through, initially Johns Hopkins was the school that continued to show us the data, to keep track of the data. And then of course, we started looking at our own Georgia Department of Health and looking. So really helping our students to identify best resources, the most accurate. Where do you go and find the most accurate, most up-to-date information so that you can see? Because with anything else, you start getting all of these inaccuracies, or what is happening, even COVID related deaths. I mean, because everything started becoming, well, they died because of COVID. No, let's look back, step back. So they may have had COVID when they died. But then let's look overall, what was their health like? What was this patient's health like? So you've got to, help. We have to help students. One of the major things that we changed was just really helping them to, especially for our health informatics students, because when I'm speaking more of our health informatics students, not so much of our MD students, but from the health informatics side, you've got to do a real diagnosis. You've really got to go in there and do the history, really understand the history of the patient. Okay, COVID came, but they had diabetes, their A1C was all the way up, they were had all of these pre-existing conditions that perhaps we're going to probably go anyway. So just really helping students to make informed decisions about the data and really knowing how to use the data for the information that they really need to get out, instead of just taking it at face value. Oh, you have all of these deaths. Absolutely you do. But what was before that? What happened before that?
If I could-
Ginger, oh, I'm sorry. Go ahead.
And I just wanted to add one point that I think is underappreciated often, right? Is, you know, with any sort of data collection, data capture, always going to be errors. You'd be surprised how much, you know, numbers might not make sense, things aren't standardized, right? And all of these issues. And there are downstream effects of that, right? So for example, if I'm building a model based off of incomplete or biased data, it will only exacerbate, right, those biases, right? And so just to kind of work with students to allow them to understand what are some common issues, how is it that I can interrogate both the data integrity, but then also bias within models. I think all of those things I just wanted to add, I think are important as well.
Thank you. Ginger, I saw your head shaking. Yeah.
Yeah, well, I was just going to kind of just tack onto that, just an example of inaccuracy of data. So I'm dealing with a small side project where they want us to produce number of patients with an A1C above 9%. It's just what simply should be a simple piece of data to pull out of our EHR. And I have been working on it, you know, weeks, if not months. The report that keeps running is not right. It says that we have patients, like 67% of our patients have A1Cs above 9. Completely inaccurate. I mean, I would argue it's probably less than 5%. But with no ability, I can only use what the report gives me. I can't dive in and I've even contacted our EHR, and their answer was basically there's something being input incorrectly that is causing this data to generate incorrectly. And so we just have flat out incorrect data. And I have no feasible way of moving forward on that diabetes project, because I certainly cannot go through thousands of charts, every, couple of months in order to hand calculate those percentages. And so that's a situation where when you have inaccuracy of data for whatever reason, it just completely shuts down the project.
And that's scary. That's terrifying, because patients and families and people trust us. And if they trust us to help their loved ones or help each other and us to make decisions, and we don't have correct data, then what do? We're supposed to be the smart ones. We're supposed to be the ones that figure it out. We're supposed to be the tech folk or the people who, go and do 20 years of education, and yet we're still behind the curve. So, wow.
But I think that's also just kind of where we're having this problem with getting what I need to get out versus what IT creates. We've got to be able to put this together where you as IT can create the data that is meaningful on my side. I know what I need to see, but I get wonderful reports out of my EHR. They're useless to me, most of them.
And that goes back to my initial comment early on about the partnership and alignment. There has to be that. And without that, then you have this separation. You don't have this marriage. It has to be a marriage. So yeah, very good. Thank you.
Totally agree. And of course, it's interesting. I have so many thoughts going on in my head, but when you think about sort of the alignment of that data, you think that, and I know we're working on a project as well. And so how much can you take back to your EHR partner vendor to help them for them to help you to disseminate and discern that data, and really go through it with a fine-tooth comb. And sometimes it's just something in the algorithm that's associated with that particular report. but where do they align with you to make sure that you're getting what you need? So, so Dr. Muhammad, I will actually switch that over to you because I think that's one of the areas that you're focused, but I also want to tack on to that before we get to our final question. I want to tack on though, where do you see, again, sort of AI and machine learning going forth with clinical decision support in healthcare?
Yeah, two really important questions. I could get on my high horse about EHR companies and vendors and how they make
I think we all can. I think everybody on this call probably wants to come off mute right now and have a conversation.
Yeah, but the short answer is, I think at some point we have to be willing to. I don't know. Actually, I don't have the answer to that first, but I think we're all on the same page there. But as far as kind of the second one, I think there's a really interesting statistic that I came across a while ago, where they talk about how I think today about 4% of all clinical and non-clinical, but within medical context, interactions involve some sort of AI enablement, machine learning. And by 2023, that's going to go up to 20%. And you could imagine 10 years from now where that's going to be, right? So I do think that it is going to become ubiquitous on the administrative side of things, as well as becoming more of an adjunct to clinical decision making. I've had many conversations with folks about, what role will AI and ML play as an adjunct. I don't think that they will necessarily replace clinicians. I think they will provide more of a, second opinion. I'm working on a project right now where one of the things that they're trying to do is actually digitize kind of expertise within very specific medical domains to make those more accessible to, let's say, rural communities, things like that. And so I think that's kind of generally where things are going to go. And I think we're just the pace of innovation is going to just increase. So we talked at the beginning about identifying new drugs and therapies. That's just going to, take off. I already spoke about expert systems as an adjunct. I think another thing that I just want to emphasize is I think it's important as we start going down this way is this idea of culturally congruent artificial intelligence, right? This is data that's going to be trained. So for example, in speech to text, right? The words, somebody uses might very well be different, right? How one expresses themselves might be very different. We're actually working within our clinical research center, collecting all data from all of the participant and patient interactions with the clinical trial, right? Everything from recruitment through engagement, and try to identify what are people talking about? How are they saying it? Being able to quantify that and build more culturally congruent models for both participation and engagement, knowing when to, in industry, one of the projects that I worked on was building a model for a marketing company where they have this billions of data points on, I've sent somebody an ad or an email. Did they open it? Did they click on it? When did they do that? And then from that, we're able to develop a model that basically says, okay, well, for this person, you should hit them at this point with this picture, whatever. I think everything is going to be tailored in that way. I just think that, we just need to make sure that the data that these models are trained on ultimately are reflective or representative of the populations that we're hoping to serve. So hopefully that answers the question. I'll end with this. Actually, no, I think it might be the last question, so I'll save it for the last one.
Sounds good. And Phoebe's on, so that means our time is getting short. I think that we could go on, and we, if we had the opportunity again, we could open mics and have a real much broader discussion as well. But I will end with this, and I would like for each of you to answer this question. It's it's your pipe dream. It's what if you could just write it out and it's paid for. And I mentioned earlier, we know the digital health tool itself is a digital health tools is a $10 billion industry, right? So I mentioned that earlier. And so if you had, and it's only increasing, so we know technology will continuously change. But if you had all the wishes and all the funds and everything you needed, and you could instantly change one technology barrier that impedes patient care, what would that be? Mr. Holmes, you can, I'll ask you to start that one. Being in technology.
Okay, so let's see. If I could just to remove barriers for patient care. Well, I mean, the most obvious one is the financial barriers. So, because so many patients can't afford the medication they're prescribed, or the transportation to get to the doctor, or the devices that they need to support their health. So, I would like to see, if there is a way that, if you have a medical problem, that just shouldn't be, finances shouldn't be a worry. So, so if I could wave my magic wand, that's kind of the direction I would aim it in.
That's right. Health equity, I love it. Dr. Howard.
Well, he really took mine because I was going to say health equity, social determinants of health. And I just got to stay there. So I'm not going to change it. That's where I am.
I appreciate it. I appreciate it. Let's Deborah, what would you say? Ginger, my good friend.
So, of course, at the end of the day, any care with or without technology is better than no care. So, even on a paper chart, having access to be able to give someone care is of course the first line. Beyond that, from just a technology and clinical part, is I would love to be able to go on and pull up my chart and see quickly and easily, 2 minutes or less, what has transpired with my patient since I saw them last. So many of my patients has seen their cardiologist, had a med change, has had an echo, have gone to their nephrologist, have seen them, got their blessing, had gone to an urgent care and had a urinary tract infection. There's so many things that has happened since my last visit. I would love to be able to sit down and open their chart and it just magically all be there, but also be there in a way that I can actually absorb it. So many of my patients love to say, oh, well, they sent you the report, it's in the chart. I'm sure you already know this. Everyone says it's in the chart, it's in the chart, it's in the chart. And I hate to break their bubble, but it may be in the chart is like saying that it's a product on Amazon. It's there. That doesn't mean that I have had any opportunity to see it yet, read it, process it, if I could even find it.
I do have one comment about that, though, real comment, is that just because the educational piece, it's about my role at Georgia Health Information Network. Every Medicaid provider in the state of Georgia has access to the web portal, and it has something similar that what you mentioned. It has a chronological listing of all of the data that they have on that patient from various hospitals. So if they were at Piedmont or Emory or Wellstar or different places, it actually has a timeline that says medication here, sprain their ankle here. Now it's not 100% full. It's not every hospital, but that's what our goal was, is to connect all the hospitals to provide what you just mentioned. But any Medicaid provider in the state of Georgia has access to that today.
Isn't that great? I mean, and so that's really the crux of all we're talking about today is that interoperability. And we spent a lot of time talking about that a little bit earlier, and just having that longitudinal patient record of having the right information for the right patient at the right time. And that's that super highway that's so critical to patient care. It's still a pipe dream. And, just not just in Georgia, but nationally. I think Gary mentioned care equality and the eHealth exchange. And those are some of the national exchanges that are out there. And there's some pieces of data, lots of pieces of data that are not there, but having that. So I like that. And I know that is certainly the goal. I was at HIMSS not too long ago, several years. I think it was my first HIM, and I heard HIMSS, and I heard George Bush speak, and he specifically said, I don't think I used the word interoperability, but I want to be able to, if I was on an accident on the side of the road in rural Texas, I want that clinician or physician to be able to pull my record and know everything about me. And that's when the HITECH Act came about. And that was his impetus. And at least that's his story, and I remember it as I remember it. So thank you for that. And Dr. Idris, I think, was this the question you were hoping I'd ask?
Yeah. So, my big thing would be policy. right? Whether that be policy, like the High Tech Act that forces, a very archaic industry to get with the times, or policy that I feel is important to be able to see kind of the innovation be kind of implemented within on the clinical care side of things, right? And so I can't count the number of conversations I have with folks, primarily clinicians, who are just like, well, if I'm making a recommendation based off of an algorithm, who am I going to be held accountable, right? It's kind of it's the age-old argument with driverless cars, right? If there's an accident that happens, who's in charge? Is it the engineer? Is it the driver? Is it the manufacturer? I think that there are models that exist that can be applied, but I definitely would love to see something like that within healthcare.
Well, thank you. Thank you all. I really, really appreciate it. It's been an engaging conversation. And I know that I've taken each of you from something else you could be doing, and we greatly appreciate you spending your time with us. Phoebe, I will turn it back over to you.
All I can say is, wow, wow, wow. That was wonderful. I appreciated the perspectives you all brought. And again, as Carmen said, I really want to thank each and every one of you who attended today and who were our experts for joining us and sharing your insights, your wealth of knowledge, your experience. And something I gathered from, this last panel is that I think clinicians need to invent the EHRs going forward. So I'd also like to thank Selena Williams for coordinating the logistics and the technology aspects of today's event. Everything went so smoothly. And we want to ask you to please be on the lookout for an event evaluation survey. It'll take just a few minutes to complete it for us so that we can get your feedback. And we thank each and every one of you and wish you all health, the real wealth, now and always.